For those of you who don't know me, I'm Sarah Fitz. I'm one of the faculty in the College of Nursing. I'm in the Department of Biobehavioral Nursing Science, and I'm the chair of the Equity and Inclusion Committee. And the committee is really excited for this meet and learn session that we have. We've had some students who have agreed to facilitate this session. These are students, members of the Student Nurses for Social Justice, and they are current students as well as recent graduates. And they're going to be discussing some student-driven anti-racist curriculum changes. And I'm going to let them go ahead and get started and introduce themselves individually.
Hi, my name is Teresa Gibbons. I use she, her, and I'm a recent graduate of the grad entry program. Maybe the 5 of us will just go around and say hello, and then we'll get started.
Hi, I'm Julia, and I use she, her pronouns, also a recent graduate of the grad entry program, and I'll send it over to Madison.
Hi, everyone. Amazing to see you here. I use she, her pronouns as well, and I'm also a recent grad, so happy to still be here. Sam.
Hi, all. My name is Sam. I use she, they pronouns, and I'm in the current grad entry program, my 2nd year. I'll send it over to Ariel.
Hello, my name is Ariel, and I also use she, her pronouns, and I am a recent graduate as well.
Hi, my name is Michael Afeni. I'm in the program as well.
All right, I'll begin screen sharing, and Teresa will start off our presentation.
Great. Thanks again for being here. As Dr. Fitz mentioned, we are grad entry students and alum connected through Student Nurses for Social Justice, representing a larger group of students that's been meeting for about the past 12 months. During the larger national conversation about racism in this country, we've been interested in how structural racism persists in nursing education, nursing curricula, and here at the UIC College of Nursing. Wonder if while we're gathering here, if you could just put in the chat your name and your affiliation or your role at the con, just so we have an idea of who's here. It's great to see so many faces. So if you have a chance, just put your name in the chat and what department or what your role is. So as we get started, we want to say that we recognize that issues of racism coexist and intersect with other structural inequities such as sexism, xenophobia, and transphobia, which we can see playing out on the broader stage and in the world. Today, we will talk about our experiences, observations, and expectations for nursing education at UIC. And obviously we represent a student perspective, but we want to invite all stakeholders and make sure that everybody who has a stake in making the College of Nursing a great place to work and learn has an opportunity to contribute, and that we can work together, hopefully, to make things better. I'm going to let Ariel get on the next slide here. You're on mute.
All right, we're going to talk a little bit about what actually brings us here. So the development of a method for discussion for racial issues in a safe and respectful learning environment is critical to the future of the nursing profession. We put this quote up here just to show that as we are nurses, we are also supposed to be culturally competent as well. So in order for us to be a well-rounded nurse, it's necessary for us to understand some of the struggles and triumphs that our patients will also be going through, that we may be able to offer different perspectives as well as solutions to any issues that they may be facing. So one of the things that we would like to bring up is race and understanding the issues that different ethnicities face throughout life.
By further way of introduction, we plan to go today for about 45 minutes, and we hope this will be interactive. We have up to an hour in case we want to talk more. And specifically, we want to talk about how can the con live up to its commitment to anti-racism? How can we remove racism from the curriculum? And how can students support these efforts? In nursing school, we spend a lot of time learning about risk factors and whether they're modifiable or non-modifiable. We've learned that race is non-modifiable. However, we do know that racism can be changed. And so we're going to do a few key definitions before we launch into discussion. Send it back to Ariel.
So one of the key terms needed to understand and to fully grasp is structural racism. So structural racism is what causes social determinants of health. It's the public policies as well as the institutional practices and cultural representations that have turned into norms within our country as well as within our systems. So on the diagram in front of us, we see how the governance as well as microeconomics and social policies will influence social groups, and that therefore will influence behaviors and biological factors. One example of this can be seen as Jim Crow or Black codes, as well as redlining, how some of those have become social norms and have been embedded within the government system in different ways, and that now influences the places that people work, homes, education, and access to healthcare. So the way that that influences everything is an overlying term and cause. So we can't learn about social determinants of health without learning about social racism and how certain policies are in place and they affect everything else.
So we're going to be using the word anti-racism a bunch throughout this presentation, so we just want to clarify terms. Kendi said the opposite of racism is not no racism, it's anti-racism. So it is defined as actively opposing racism by advocating for change in political, economic, and social life. Next slide. And so we want to ask you all, what does an anti-racism curriculum look like? So we invite people to, maybe a few people to share what they think this looks like, and also feel free to use the chat.
Sorry, I couldn't find the unmute button. I think an anti-racist curriculum, like for me, one of the things that I've noticed a lot is we don't always talk about the way that incorrect theory is worked into our textbooks. Like there are these big expensive things that we all have to invest in, and we're not always very like conscious, or like we don't spend time talking about the ways in which like the textbooks are failing us, or how they're implicitly problematic.
Good point.
Thanks for sharing. Anyone else want to throw their opinion in the room?
Some in the chat. It says addressing. Oh no, I just lost it.
I can read it. It's learning how
disparities and clarifying any misconceptions of any particular race group we have, and also learning how skin conditions look on diverse skin as well.
Exactly. I think also we have one more coming in, incorporating historical perspectives and how they impact current health and outcomes inequities. Great, so we're gonna go a little bit further into what we think an anti-racist curriculum looks like. But at the end, we're gonna invite people to maybe share if anything comes to mind that maybe has not been named.
So one of the things that we wanted to touch on was the curriculum change. So we wanted to see a curriculum shift in how it addresses controversial healthcare topics. Two specifically came to mind, which was the PFT as well as the GFR. I bring up the GFR because within class, they stated that African Americans have a different ratio than their counterparts, as well as within clinic, if you go into EPIC, they'll have two different GFR ranges, and the one for African American has AA in front of it, which is a entirely different range of numbers. And what that leads to is a change in care. So in order for you to receive a kidney transplant, you have to be within a range for you have to be within a specific range for GFR, which is if your range is different, that could potentially knock you out of the running to get a kidney, which is completely unfair, and it is not the same care that everybody else would be provided. You also need to look at precocious puberty as well, where it's stated that African-American young girls will go into puberty before their counterparts as well. There hasn't been any explanation as to why that is during class, as well as different medications prescribed for different minorities due to a certain threshold. But there hasn't been any information given during class regarding why different medication was prescribed for different minorities. So that can go into beta blockers, ACE inhibitors, as well as diuretics. We also want to look at addressing the structural determinants of health beyond structural determinants of health beyond social determinants of health. So we touched a little bit on what structural racism is, and that also plays into what structural determinants of health. So we need to look at that race is not the cause, but racism is. We need to dive into looking at what type of barriers are in place caused by the structural determinants of health. We speak a lot about how African Americans or different minorities are at a higher risk for certain diseases when it's not the race. It is strictly the environment in which they come from. So anybody that lives within that environment is prone to have those conditions. It's not just those based on the race. So once again, it goes into name that racism, not race, is the cause of health disparities. One of the things that I do remember talking about in class is cardiac health, where they say African Americans are at a higher rate, but it really is the structural determinants of health that play into that as well.
So we want to give a few examples of kind of ways that faculty have positively incorporated these kind of changes that we would like to see, and some opportunities for future improvement. Some faculty have used guest speakers to come into class and lead discussions on areas that they themselves don't have experience in. Some faculty at the con don't represent as many cultures and backgrounds as the students do. And at times, students may be able to add their own value and speak to their own expertise. We would encourage faculty to continue to bring in guest speakers that can speak to experiences that they might not have, and also invite students to share on their own lived experience. The concept of intersectionality has been introduced in courses. We would like to encourage that to be a thread that kind of runs through nursing curriculum, as it has so many impacts on our patients and the different oppressions that people face and how those are linked. We are challenging the College of Nursing to conduct an audit of the curriculum to identify practices, policies, and curricula that are inconsistent with the established anti-racism, diversity, equity, and inclusion goals. And here are some examples where we see an opportunity for improvement. And 519, which is the social determinants of health equity and social determinants of health. This is a required course in the first semester of the grad entry program. it was and still is online and asynchronous, and 100% group based without ever even having a recorded lecture. I think a lot of us felt that this class was going to be a great opportunity to start talking about social determinants of health and some structural issues that uphold inequalities. But unfortunately, there was no opportunity for a facilitated discussion in this course. And we feel it was a missed opportunity to help students understand health equity issues. It would be important for this course to define not just social determinants of health, but the structural determinants of health, which encompass not just housing conditions and pollution, but the distribution of money, power, and resources which precede the social determinants of health and continue to uphold them. Because we do, as nurses and as humans, have the ability to challenge these systems. And it would allow, for instance, it would allow us to talk about racism and not race as a factor in health outcomes. Another course that we identified was the series 515 and 516, which was evidence-based practice 1 and 2. We spent 2 semesters on this. We hope that in the future we can include a conversation and critique about who determines and what constitutes evidence. Can we discuss and legitimize non-traditional research frameworks, such as community-based and participatory research? So these are just a couple concrete examples of areas in our curriculum that we felt could be enhanced and could be identified in something like a curriculum audit. Go to the next slide. You can do the next slide, Julia. Oh, thanks.
Thank you. So we want to just ask all of you to share, what do you think your role could be in building a culture of anti-racist nursing? And there's no, this could be various different examples. So please do share in the chat or over your video if you'd like. What do you think your role could be in continuing to build a culture of anti-racist nursing?
Alexa, spell model.
Model is spelled M-O-D-E-L. Do you want that one more time?
No, thank you.
Please mute yourself unless you're contributing to the discussion. That'd be great. Thank you.
I apologize.
We have one in the chat box from Michael. It says, keeping an open mind when we meet and talk to people. And Lenny says, being a role model.
I'm just going to suggest, as a faculty member, we will be reviewing our curriculum going in the not too distant future, probably this summer, in terms of the new essentials that have been put out. And in that time, we, not that we should wait until then to make some changes, but we certainly can take a very discreet and thoughtful look at the curriculum. And that's why it's so valuable to get input from all avenues, from the faculty, from the students, from our recent graduates. So I appreciate this, but I think that is going to be a large role as a faculty member that I certainly can play.
And if I can just add on to that, or challenge, I guess, that we're thankful that is happening. We are aware after conversations, and we'll get into that a little bit later, but just as a challenge, how does one prepare themselves to go about that, I guess, because it comes with a lot of power.
I also have a quick question. Will students at different levels be involved in that process of evaluation as well?
I'm not in charge of it, certainly, Lenny, but I think that there is a role for everyone to play in the development of the new curriculum. So from my standpoint, I certainly will advocate for that, and I expect that there will be. But we're not even, it's not even, we know it's coming, and that's as far as we've gotten, as far as none of the planning or nothing's been put in place at this point.
I also see Dr. Fitz. You have your hand raised as well.
Yes, I was just going to say, we've been trying to have discussions among I know among the DNP faculty and others about ways of bringing up and discussing some of the guidelines and the assessment parameters that you mentioned, Ariel, including the 2017 hypertension guidelines that haven't been updated. GFR is finally, the multiple kidney, multiple renal, nephrology organizations have come up with a non-race-based GFR calculator that should be instituted in hospitals if it hasn't been already. We're trying to discuss ways to bring this up during class, even when it's challenging because the hypertension guidelines haven't been changed, even though they include race, and that is, and I think trying to call out race-based and racist guidelines and historically racist practices is important. And I also think that curriculum changes should include students. One thing that I found really helpful is students have in their course evaluations, I know everyone gets tired of doing the course evaluations, but multiple students have brought up lectures that are outdated and need to be updated and include race as a risk factor as opposed to racism. And so that's been really helpful to me as an educator to have those things called out.
Thank you, Dr. Fitz, for sharing. I see Dr. Matthews as well.
Hello, good afternoon. Thank you to the wonderful panel for providing us an opportunity to learn from your experiences with the curriculum. I have a question for those of us who are not clinicians. Can you please explain a little bit more about what the concerns are in terms of using race as a clinical indicator when looking at lab results? Because we know from the research that there are some examples in which for example, I'll use the pulse oxygen measures for the finger. During the height of the first year of the pandemic, it was come to light that it was highly inaccurate in reading the appropriate oxygen saturation levels of individuals with darker skin tones, because the developers of that device created them all using lighter skin tones. And as a result of that, it wasn't accurate. And so being able to adjust the ranges for intervention would be appropriate in that way. So are you talking about something different than the example that I'm just describing that would be good for us to understand, for those of us who are non-clinicians to better understand?
I'm sure there's other experts who can speak on this better, but I think Dr. Phoenix, in that example that you gave, it has to do with the development of technology and inaccurate measurements. I think that some of the examples that Ariel gave about pulmonary function tests and GFR, and then hypertension, like Dr. Fitz raised, was just an objective standardized criteria for certain interventions that were different based on race, and not because the measurement was inaccurate. Anybody else can expand.
I also want to highlight that, like Dr. Phoenix, like, that's exactly the conversations that need to be had within the college. That some tools that are currently being had are actually not appropriate for the wide range of populations that nurses work with. So I appreciate you raising that.
But I guess that's what I'm hoping that we'll get to, is a real nuanced understanding of, are the race-specific guidelines in place because there's a body of evidence that suggests that for example, African Americans are less responsive to the existing hypertensive medications. The rationale being that there were fewer Blacks in those randomized clinical trials in which to come up with population-specific norms, which could be an explanation for that. So I really want us to sort of not throw the baby out with the bathwater, so to speak. So sometimes those differences in race-specific guidelines are as a result of research that has shown that there are differences. critique is still well appropriate in that the trials have not been inclusive. The clinical trials have not been inclusive of enough diversity to be able to understand that prior to putting together guidelines. But I just wanted to know if there were some examples that you had that were not based on evidence that we should be advocating to address, or have these come as a result of some evidence that shows we didn't do our due diligence in development of this measurement tool, blood sample, or medication.
I have a, I don't know if I'm even on an example. If oh, I didn't want to do that.
While Dr. Thornton is gathering his thoughts, I thank you so much, Phoenix, for kind of furthering the discussion around the research background aspect. I think that Sam put it in the chat, but an example of how there are some existing clinical guidelines that are based in either a total lack of research or research completed in the context of racism. For example, the pulmonary function testing, the research that backs up the difference between African-American and white patients is from the era of slavery, when doctors were essentially, researchers and doctors were essentially trying to support their racist ideas about the functionality of an African-American person's body, and in this case, the lungs. And so there are examples of current existing clinical guidelines that are simply based in untruths. And that is a really helpful reminder. Thank you.
And also to add that rationale was used to explain or to better rationalize slavery, like the assumption that Black folks breed differently, and that's the reason why it's okay that they're slaves. Like, obviously we don't believe that nowadays, but that that logic came from deeply racist beliefs, and it still lives in our tools now.
I was just going to add to that the example of the glomerular filtration rate and the determination of treatment for, including transplant treatment for chronic kidney disease. I mean, this is one of the guidelines that's now been, or one of the lab calculations that's now, we're trying to reverse it. And that's that there was an adjustment made for African Americans that basically made an abnormally low kidney function seem as if it was in a normal range for African Americans, despite the fact that that then disadvantaged them in terms of getting early treatment and getting early listing for kidney transplant to be an option, which was based in historically racist context. And the hypertension guidelines, I think it's a lot more unclear. The research supports the use of certain medications specifically for African-American patients, but the research itself is extremely hard to interpret because there's an intersection between the patient populations that they evaluated and a lot of social determinants of health that are based in historical racism. So it's just really difficult to weed out, which I think is why kind of the intersectionality of all of that becomes challenging. And I think for me as a clinician, I keep coming back to the fact that race is a social construct. There's we don't, for a lot of these guidelines, we don't have a lot of evidence that genetics correspond to what we are saying is race. And I don't know if I'm saying that correctly. So please speak up if I'm not.
Do you mind if I jump in there,
Dr. Fitz. So, I certainly appreciate everything that's being said. I spent a lot of time working in the kidney transplant field. And I agree with the EGFR calculation being based on race, and that it seemed like it always seemed to me it was a way to try to account for these social determinants of health, which is, completely wrong, because it disenfranchises many African-American people to the opportunity to receive a kidney transplant, which, it's a community that already faces significant access issues to transplantation to begin with, without, needing any help from this kind of skewed EGFR calculation. But I do want to say, though, that, there are cases where we see, different gene variants that are different between different groups. For example, the APOL1 gene variant is more prominent in African American people, and it predisposes them to be at higher risk of kidney disease. So I think, to kind of tag on to what Phoenix was saying, we have to be careful not to label everything as racist, because there are, some things that are different between people of different genetic ancestry, and we need to be aware of that, because if we don't pay attention to those things, we're doing a disservice to our patients too. And as I say that, I want to give a plug by saying, one of the things that I think nurses also need to focus on more is about having a better understanding of genomics and how they affect our patients too, because we're entering the age of genomics and omics, and really that's another thing that I think will help clarify some of these differences too. The role of genomics has come a long way, and I think can help us kind of parse a lot of this out. So.
This is a very rich discussion, and honestly, I have a lot I would love to respond to you, Mark, but I also recognize that it's 3:30 and I want us to kind of stay focused on the presentation. So I think maybe we should continue on for now, and maybe we can continue the discussion at the end once we have time.
All right, thanks, Sam. Thank you all, and I look forward to further discussions ongoing. All right, so we really want to discuss in depth the aspect of support and accountability for faculty. So faculty and staff and instructors within the CON are the ones with the most immediate opportunity to change the way that students learn. And we're so grateful to the ones by whom we felt supported and challenged by in our time here. And we really want to see the College of Nursing equip faculty and instructors with tools and training to identify racism in nursing textbooks and other sources, and encourage learning and discussion about racism in the context of nursing. We have a number of examples from professors who've already been doing this work in their teaching, and we acknowledge that we can only speak to our experiences, and I'm sure there are other examples that we have not witnessed ourselves. Teresa shared some of the examples of how professors include guest speakers who can speak to their identities and then facilitate discussions with that speaker and after the speaker's visit, and how crucial that is to learning process. We also have had a great example of a professor who helped facilitate an audit of the clinical simulations for the pediatric and OB courses in an effort to eliminate bias, and ensured that we discussed bias and racial discrimination as we debriefed those clinical simulations. We also have had professors who have been intentional about including reading materials written by diverse authors from diverse backgrounds. There have been professors who have very intentionally brought up racism and not just racial disparities as a structural determinant of health, and made an effort to include updated information and research related to how it connects to the topic they're discussing, as in pathophysiology. I had an experience this past semester where I noticed significant bias in the way a professor discussed obesity in the context of learning about metabolic syndromes, and I was able to reach out to them and have a discussion about what I noticed, and ultimately felt that this professor was willing and able to think critically about their work and be generous with their time, as well as their commitment to change. And that being said, as we have been discussing, we want to keep acknowledging the intersectionality of all identities and the relevance of this example to our greater conversation here. And though like today, the Office of Equity and Inclusion offers meet and learns addressing these types of topics, which is so important and so crucial, we note that these meetings are not mandatory, and we believe there should be a mandatory workshop for all faculty and instructors, including visiting, to improve their ability to incorporate equity and inclusion in teaching, assessment, and curriculum. Educators at the University of California, San Francisco, UCSF School of Medicine, created a great example of this, and they called it Teach for UCSF Certificate in Teaching for Equity and Inclusion. And their example encouraged self-awareness and understanding of equity and inclusion concepts in medical education, and offered tools to actively address bias in their teaching and the design of their curricula and their assessments. Something that professors could begin doing, if they are not doing so already, is acknowledging their identities and positionalities at the beginning of their course each time they teach it. So many of you are familiar with reflexivity statements, which I completed alongside research efforts, and this could be similar. This would really set the stage for the course to have honest and self-aware conversations among students and faculty alike. We also believe that it is crucial that there be improved transparency around bias reporting tools and the process of addressing complaints. And now that the bias reporting link is widely available, we believe students deserve to understand what happens next after that report is made. And finally, students need to have a vote and a voice on leadership committees within the CON. And we want to be a part of this conversation to ensure that this happens in the very near future. This is crucial to ensure accountability among all faculty and staff at the CON regarding ongoing growth and change. And of course, the example of having Tierra Brazil from GSNO representing students for the curriculum committee is a wonderful example. And we wish to see more of those examples of student voice. And we want to ensure that students on those committees have an actual vote in making decisions for the greater College of Nursing. Thank you.
So we're going to talk specifically about coursework that directly addresses racism, because you can't fight racism if you don't see it or understand it. Nursing has been complicit in upholding structural racism and scientific racism. Therefore, we need coursework that helps students understand systemic racism and how it lives in nursing and its history. There was a quote in a recent article by Waite and Nardi in 2021 that I really liked. I think it brought out a lot of what I've been thinking for a while, that understanding the evolution of anti-Black racism, historical trauma, and whiteness is foundational to understanding intergenerational trauma and present-day health inequities. This quote points out how important it is for future nurse leaders to engage in these topics as part of the nursing curriculum. Students should engage in coursework from authors and editors from various backgrounds. In the same way, we hope students have diverse instructors. Also, concepts of racism and UIC's commitment to anti-racism should be named early on for incoming students, especially in orientation. It should be clear to students what resources are available, such as the bias survey, if an issue comes up and it needs to be reported, as well as past, present, and future efforts by the CON to shift the bones of the college to address racism. The college should also clarify how students can get involved and be part of the process. We're a student-led group here, and we believe that students are not only willing to be part of this work, but they can be an asset in curriculum changes. Finally, we strongly believe that the CON should incorporate a course that explicitly teaches the history of racism in medicine, public health, and nursing. Learning why PFTs are problematic, learning why, just like understanding how nursing has actually supported racism in some ways and been complicit to it. I was lucky enough to take a course called Racism in Public Health, and it was a public health course. This course gave me the foundational knowledge that equipped me and all the other presenters that are currently speaking with you today in order to speak with you all. And we not only understood the history, but also the research evidence of kind of why these topics are so important. Yeah, and I feel so privileged to have been able to learn from Linda Ray Murray and Richard David, who both led that course. But I think this body of knowledge should live in the College of Nursing and should be prioritized. It shouldn't have to be an extra course that people have to take in addition, and it should be centered in our current curriculum. The college does a really good job incorporating information from speakers, especially Meet and Learns, but I wish that these topic areas can be more front and center in the classroom. And then finally, Northwestern Medical School has all incoming students read How to Be an Anti-Racist. And this book builds knowledge for students, but it also sends a really powerful message to students that racial equity work is important in their equity practice. For that reason, I would suggest that the College of Nursing adopts this practice as it continues to shift its curriculum. Next slide.
Okay, so we have a couple more questions that we would really like to continue our conversation with. This first one is, consider a world with anti-racist efforts weaved throughout. How do you envision that liberated world? So if people could continue posting in the chat, we love everything we've seen so far in the chat, but also feel free to just jump in. Another way, while people are thinking, another way that I've thought about this question, or I guess maybe what I've been thinking about recently, as we are now in 2022, is the huge uproar and racial reckoning we saw, especially among white activists and advocates in the summer of 2020, why that happened when it did, and also why people have either assumed that they have reckoned and moved on, or why it's gotten so quiet and how we can sustain our efforts. So we want to talk about this. This question is really to invoke what is our vision to help us understand how we can get there.
So we have some things in the chat, more trust between providers and marginalized groups. We have a world where people's truths are believed and respected. Let me scroll up. First steps, get better in seeing and naming in nursing. So in the College of Nursing, when we see it. And we have as a world where I could finally breathe. And better health and less suffering for all, and seeing and naming examples of where structures of racism exist. Well, it's coming in fast. A world where no assumptions, judgment, or hatred towards women who wear a headscarf. Respectful acceptance of differences. And I know there's one more. People recognizing that bias occurs and working to address their own individual biases and systematic bias. Promoting an environment where both students and faculty can feel comfortable talking about racism. These are all amazing. Thank you guys so much for sharing as well. Healthcare systems designed around people rather than other way around, and where we recognize the difference between equity and equality.
Phoenix, I see your hand raised.
These are fantastic, but I'm also intrigued by, in terms of having the discussion about what you added after this. Why have we gotten so quiet? There was a moment in time when a lot of folks stood up and marched and worked and grappled. And now a lot of us are back very comfortably in our seats again. What happened?
I personally believe everyone go back to normal. During that time period, we were stuck in the house and there was nothing for us to look at but the injustices that were being shown on social media, TV, the news, and now we're able, since the world is opening back up again, we're able to sort of distract ourselves with that. And I feel like especially if we're not affected by it, then it's easier for us to ignore. So it may be something you are complacent with or something that you're able to ignore, whereas others, it's something that's right in their face. That's just a personal opinion.
I also think, and this was inspired by a podcast I was listening to, an NPR code switch, which I can post the episode for, but I do think it's, and this is what they talk about, but it's really political. People were enraged, and I think it was political. And I think the key to that is knowing that to be a part of this, for me personally, is seeking for policy change, seeking for actual policies within College of Nursing, within our communities, within our local governments, that can make a difference, rather than just reading a book and posting something on social media or doing whatever research we need to do on our own. It's becoming more vocal and more active in a political way.
Next slide.
I think, Phoenix, we could have an entire meet and learn discussion about just that, and I'd love to be there. But in continuance, are there any anti-racist curriculum changes you envision that we have not addressed?
I see we have a hand raised. Kate Treadway.
Yeah, just one that comes to mind is not just the curriculum, but how we deliver it.
What were you saying?
No, I'm not there.
I think that we have to be aware of, you know, things.
Sorry, 1 second. Can you please mute yourself if you're not speaking? Thank you.
So my comment is not just the curriculum, but how we deliver it as well. And by which I mean things like how much are we asking students to pay for textbooks? You know, can we do some things online? And if we do them online, are we aware that our students have access or not to computers and Wi-Fi and these kinds of things? How we put exams online and then proctor them. There's a number of different issues that I think that I call the infrastructure of delivering a curriculum that I think would need to be addressed as well, and that we need to continue to address. Thanks.
Thank you so much for sharing. Dr. Singer.
Hi, thank you so much for organizing this. It's wonderful to see so many people here and the work that you put into this. And this just sort of follows on what Kate is saying, that I think also, so, you know, we moved to a more holistic admissions process in order to diversify and make our student body more representative of the city of Chicago and the communities that we serve. And we've been, you know, there has been, you know, the student body is more diverse than it was a decade ago in that way, and more mirrors the city of Chicago. But one thing that I have seen, and it's anecdotal, and I don't know the numbers, and Office of Academic Affairs would know, Kate Vincent, but I think that we also have students that struggle, and it's often more students of color, so that they're not supported. There aren't as many role models in the faculty, and that's something that many of us on faculty are very concerned about and have been talking about for years, is getting role models that represent the students that they can connect to and can support them. And that also just more supports for our students so that they do succeed. So it's not only the curriculum, but how we deliver that curriculum and support the students so that we can create that nursing workforce that is more diverse and more representative and thus anti-racist, and really rebuild that culture of nursing.
Thank you, Dr. Singer. Dr. Fitz.
Thanks. I can think of a lot of things. I'm just trying to keep it brief. I do think, I mean, we need to continue working on the pipeline issue. Like Dr. Singer said, we don't have a diverse enough staff and faculty to support our diverse student body. We're trying to increase the student diversity, but the faculty doesn't mirror that. And in addition, I think we need more faculty support and more protected time to work specifically on required curriculum changes to make our curriculum anti-racist in nature. I think a lot of faculty, I've talked to a number of faculty who want to make changes like this, but aren't really certain what the first steps are. And I think that having a little bit more of a toolkit and also having some more time dedicated to this from a faculty standpoint would be helpful. That's my personal view.
Thank you so much, Dr. Matthews.
Sorry for taking up so much airtime, but I do feel a little bit compelled to respond. Rebecca, thank you for pointing out the the lack of resources for students, but I think we would need to be extremely careful about connecting holistic admissions to the underperformance of some of our students. And I'm certain that that wasn't your intention, but one of the things that frequently happens in the college is that there has been, even nationally, there has been a lot of backlash about holistic admissions. And the idea is that, we're watering down our standards, but what is happening in actuality is that we are expanding our standards to be inclusive of additional endpoints that are also predictive of success. The idea that we would be exclusively, and this is not in response to Rebecca, this is me just sort of explaining a little bit of the background of this issue, is that we would exclusively rely on GPAs and standardized test score. We know there's a strong association between those two things and social economic status. Again, where we are in our country in terms of economic equality is very clear. So right away we're baking in a structural barrier to success. Holistic admissions is anti-racist because it expands the criteria by which resiliency, persistence, leadership, and grit is analyzed. Now, we don't throw away academic endpoints entirely, but we do try to balance those with other indicators of potential for success and leadership. And as has been pointed out, we've been very successful over the last decade in terms of diversifying our student body so that it looks much closer to the city of Chicago. And that's been very positive. But then there are people who are naysayers, say it's affirmative action, and that it has resulted in a lessening of our strength of our students. And that it's related to the current issues that we're having with NCLEX. The holistic admissions has been evaluated here in the college. It has not been associated with a lowering of our student GPA or graduation rates. It wasn't looked at in relationship to NCLEX, but the NCLEX scores, there are lots of noise in what's happening with there. And to link that specifically to holistic admissions just is incorrect. So resources, yes, decoupling with who comes in under holistic admissions. Thank you.
Thank you so much, Dr. Phoenix. Go ahead, Sam.
Yeah, I just want to say thank you for adding that complexity. If you can shift to the next slide. We want to tell you about next steps. You're not done with us. This is just the beginning of the student-led group talking with you all. So it's been previously talked about, it is our goal, and also to name, we're a bunch of students coming out of Student Nurses for Social Justice, which is a club on campus. And so our goal is to have student representation in all aspects of anti-racist work at the Con. And this is particularly important at the curriculum updates that are happening this year. And so we're trying to figure out what student representation looks like and how we can have input in that work. Also, there's been an ask for resources. Well, we've been using a list of resources or at least our group has been amassing resources that lives in this Google folder that we're happy to share with folks that are interested in. And also the previous grad entry students that are talking with you today, the cohort before me, when they took the racism and public health class, they created a report of suggestions that are kind of amassed in this presentation right now. But if you want to read the report, that is also available in this folder. We invite you to contact us at the Student Nurses for Social Justice email here. And we want to be in communication. We want parts of the college to reach out to us being like, we want more communication with students. We want to be able to talk this out. But sometimes we don't know the opportunities unless someone reaches out to us. So this is an open invitation to talk with us. This is an ongoing process, and we hope that this is just the beginning of a relationship with us, and that this can be kind of a two-way communication. And we also want to put in a plug on January 31. There's going to be a virtual conversation with Linda Ray Murray, who did lead, well, she was a co-leader of the Racism and Public Health course. And so she's going to be talking about battling systemic racism as a practitioner. And so she worked at Cook County Hospital for many years. And so she's going to be talking about how she battled racism as a practitioner at that hospital. Does anyone have any questions? I want to quickly add that we have been talking a lot about like not being aware what the college is doing unless they name it. And so we want to invite the college to create pathways to be more vocal about changes and shifts in curriculum, kind of as it's happening, being able to name it and share it back with students who are really interested and passionate about this topic. And also we want to name that this team of folks has actually met with the leadership team at the college. So we've met with all the deans before and shared these ideas. And so we're hoping just to disseminate this information as far and wide as possible, as well as kind of deep and in relationship building. So sorry, just wanted to quickly add that.
I'm just going to add in also, we see that Dr. David is here today with us. And we feel very lucky to have taken the course that we shouted out with him and Dr. Murray. And all of this really stems from his challenge for us to create a report on curriculum changes that we'd like to see within our own college. There were students from all different colleges and degrees in that class. And we just want to say thank you because it inspired the past year and a half. I'm losing track of time right now of work that we've been doing. And thank you everyone for being here. It's been great.
We also want to invite people to stick around if you have time for a little more discussion. I think we definitely, there's always more to discuss. And if anyone has a few more minutes, you're welcome to stay. Thank you.
There was a direct ask about how the resources can be sent out from the folder. So maybe hopefully this presentation can also be sent out through the listserv.
Hi, Sam, this is Paige. Yeah, thanks. I would love that. I've got I'm definitely gonna be in touch with some of y'all. Love that I see Jessica Lamberson here too, because I'm a huge fan club member of her, but I'll be reaching out to some of you because so I can get some better ideas about what next steps would be. So thanks for that. I gotta head out for the math review I said I was gonna do for y'all. So I'll talk to you soon. Thanks.
Another shout out should have come before, but Jessica is also an author on our curriculum changes.
And this presentation will be posted on the College of Nursing YouTube channel. And so any links that you want to include, if you all can, if the facilitators, one of the facilitators can just send me, we can try to have those links included as well.
Will do. Thank you, Dr. Fitz.
Yes.
So,
yeah. Go ahead.
No, I was gonna say we did speak briefly about including the history of nursing and just how that has come about and how that is inherently racist as well, and just how a lot of the individuals that helped start nursing have not been spoken about, and how we sort of focus on one nurse, Nightingale, when there are other nurses that were really instrumental in getting nursing across the world. So we have talked about that as well, and as well as some things with orientation too. But just spoken about it, I don't believe we've actually gotten permission or anything as well.
Hey everyone, it's Gwyneth. So I actually just developed a nursing history course last semester. It's for the RN to BSN program actually. So it uses it's like a textbook that's written for nursing history, but it comes from like a culture of health. So it really focuses on not just those like the great leaders in nursing, but more of the cultural shifts, not just white women, but looking at Black nursing, looking at nursing in Native communities, looking at sort of the parallel structure that like Black nursing and white nursing has had to take, different decisions that have really shaped both the way that healthcare is formed as well as how our profession has excluded a lot of people of color, men, and that sort of things for a long time. And a lot of that actually comes from Nightingale and the roots of how Nightingale thinks of what a nurse, quote unquote, should be. And so anyway, so this course already exists at UIC. Right now, it's just in the RN to BSN program. But if you think that there's a need from it as far as the students go, I could look into seeing if we can open it up as an elective to not just current nursing students, but maybe pre-nursing students as well. Because, I think that understanding that context of how we got to where we are and the mistakes that have been made in the past can really help us look to the future and say, okay, what is it exactly that we need to undo? And what is it that we need to watch out for to make sure that we're not making these mistakes again?
That's so awesome to hear that you've already developed this. I think the way we've talked about history, I think there's a need for that in our grad entry program. I think the class that we could envision would be a racism and nursing course that would, of course, go through the history with the lens of looking at structural racism and how we got to where we are today. So, and I think that would be incorporated. We really want that to be, we took the racism in public health course as an elective. We really want there to be a class that's through the College of Nursing. And I think that's even when we've talked to, not the exec team, but when we've talked to the dean and other people, that's been the call, is that we want this to be, or I guess their answer to our call is that they want it to be someone in the College of Nursing who could give this course. And I think that could really fill the need.
I also want to acknowledge that, in 403, Nursing 403, which is a required course in the grad entry program, we do talk about the history of nursing and get perspectives from a lot of different writers and important nurses that I had never heard of before. And I don't think I would have heard of had I not taken that course. So there are examples woven in other courses as well that kind of use humanities to help enhance education. It really is very valuable, I think, in validating for people as students to see their own experiences reflected.
I see we have a hand raised. Tony?
Hi. I just wanted to bring up something happened at the College of Nursing last semester that I was really kind of shocked by, but also I guess not really that shocked at the same time. I was in the lobby of the College of Nursing and there was a table and I walked past it and they said that they were collecting donations for their diversity and inclusion scholarships. They were collecting donations from students. And I just kind of feel like if we want to have like a more diverse classroom, and if we want to have like more diverse like educators, like we need to have like better access to like scholarship programs and things like that. And I really hope the College of Nursing isn't just using donations from students to fund these scholarship programs. Because I mean, like collectively, you know, like the United States owes like $2 trillion in student loans. And like our program's expensive, you know, and like that, you know, like creates, you know, barriers to getting education, you know, in itself. So I just really hope that the College of Nursing is doing more to like fund these scholarship programs that are much needed. So.
And if I may just piggyback off of Tony, I would like to see more faces of color in all departments of area, because it's kind of difficult. Sorry, I was driving and I just got back in, so it's my face, I apologize. But I am an African-American woman, and I don't see enough of either African-American males, females, or people of color in general in places that I go normally, because they're all dominated by white people. And it's just like, that's not how the world works. And places where you work, especially in like major urban areas, you will not just see only white people, you'll see everybody. So like, it'll be nice to see like a nursing team of just filled with so much diversity in like a floor. That's like a future that everybody's hoping for. But like, it starts really in nursing schools and accepting more people of color to be able to get change out there, because we're just accepting the same people over and over. We're not going to see that change happen anytime soon. So I'm just putting that out there too.
Thank you, Chichi. Does anyone else have any other points or questions that that came up for them after these conversations or that presentation? Anything else that would be helpful to talk through on this Zoom here?
I have something to say.
Please, thank you.
Okay, so there was a message in the chat, a student does not feel empowered to change the curriculum, but please keep trying. I'm a clinical instructor. I've had people challenge my curriculum. I think it's wonderful. I've challenged the curriculum that's been presented to me, and we have 3 mental health clinical instructors in the Zoom chat, and we've all challenged it. We do have to keep challenging it. And by the way, it prepares you for working in healthcare where there are racist attitudes. So, you know, you prepare as a student, and it can lead to policy change. So please don't be deterred, you know, feeling disempowered.
I feel like that was my comment. And like,
right, Bonnie and Lenny, you guys are with me. Yeah, I'm sorry.
I agree, Sally. What came to my mind throughout this is, how do there's just such a small group here. We have a very large College of Nursing, faculty and students. How do we get those, both students and faculty, to feel comfortable where that exchange can happen? Interestingly enough, Sally and I had this conversation just a couple of days ago. How do we get to feel that level of comfort so we can either go to our peers or welcome those comments from students to help us do better as faculty, clinical faculty, and how to get students to become more comfortable about talking about this? Because I think the conversation, starting that conversation, is a key piece of this. And you have done that, but this is just such a small piece of the puzzle. I think we would do so much better if we all felt comfortable having this conversation on a regular, but whenever it comes up, so we can do better and learn better.
Thanks for that, Lenny. I just wanted to speak to like that sense of empowerment, because definitely I wasn't a presenter today, but I've been involved with like the working group that's been meeting and planning and meeting and planning and meeting and planning. But like as a student, like we're here for 2 years and it's so quick and it's so hard to know if like bringing forward hard conversations or like fraught conversations or criticizing your teacher's syllabi is going to do you any good or if it's going to shoot you in the foot. And there's so much energy already that we have to put towards like doing well in our classes that it doesn't seem like I have time to both do well in my classes and to like have this nuanced criticism and a solution. So I appreciate seeing so many faculty show up because I know that you guys have been in this fight like way longer than any of us have. Like you've been around the College of Nursing and like seeing the changes that need to be made and making them as you go. And I appreciate the work that's been done before now. And it's good to see that you guys are still willing to engage with all of our maybe sophomoric requests. I don't know. It's really nice.
This is Kate. I've been around a long time and it's positive and hopeful in one way. You can't believe the change 5 years ago, but we've only in that amount of time gotten this far. So there's so much more work to do. But I will say that certainly a great deal of that change came from students speaking up and putting their feet down, you know, saying, you know, you're not moving fast enough. You know, that's part of the college's nursing's problem is we don't keep up, you know, with change, with new attitude, with new information. You know, we're supposed to be evidence-based. Well, come on, let's get ourselves evidence-based here, you know, and we can't, and it won't happen if students don't speak up, even in the 2 years that you're here. You know, this and this is wonderful. I don't, you know, in the last 2 years, I think I've participated in 2 or 3 of these engagements with this group. And I mean, that's phenomenal. And believe me, it didn't used to happen. So thank you all for your commitment and even with the workload and stress that you have. So.
Thank you all so much. And yes, as Torin stated, gratitude to all the people who have been doing the work in the College of Nursing and continue to, and for those examples and for the support of students. And yeah, this is such a good example of how these conversations can become normal, right? Like this can become a part of our everyday learning, and it does take work, but it's so possible and really exciting and important. And we also wanted to, one thing I wanted to note was that, of course, we're all talking about the Chicago campus today, but we recognize that the CON is, you know, 5, 6, I always get it mixed up, 5 or 6 campuses, which are all equally important. And we have some student representation from other campuses. So hopefully this can kind of like spread out into our other campuses and other in that way. And also, I just think that, of course, UIC can be such an example for nursing colleges across the country. Like this is something that we should all be just so excited about because we can spread it across and keep that going. So just want to respect everyone's time. Please, if anyone has any other thoughts in the chat or over video, like we can take another minute or 2. I don't want to cut anyone off by any means, but we do want to respect time. So thank you all so much. This is the last minute or 2 to say anything you want to say.
Okay, thank you.
Jessica?
I was basically going to say what Julia shared, but just to support those students who, one, name the power dynamic between faculty and students, and that it can be scary and be threatening to speak up, but also conversations like these make it easier to have conversations in classrooms, in clinicals, in your professional setting when you leave the School of Nursing. So yes, you're starting a conversation here, but you're going to be that leader who will lead the conversations in clinical as a nurse and as a preceptor, and eventually as faculty, you will be teaching the next generation. So starting those conversations here where it feels maybe a little safer, we'll give you those words in that practice to perhaps bond together with other students and faculty to challenge and to point out and to critique and analyze and take that as professional development as a nurse and as future faculty and future nurse leaders.
Absolutely. Okay, thank you, and look forward to seeing you all in the field.
Very good.
Thanks,
Thank
everybody.
you all.
Have a great
Thank you all.
Thank you, everyone, for making it such a good discussion.
Yes.